So talking about data is never an easy stint at a conference. And we're also running over time, so I'm going to try and be quite quick fire. I'm going to start with talking about self-harm. And self-harm often means something different to different people. But in terms of the strategy, when we talk about self-harm, what we're talking about is intentional self-injury or self-poisoning, regardless of motivation or intent. And what that means is that under that umbrella of the term self-harm, the range is from people who might be cutting to manage emotions to suicide attempts. And the reason that's important, because there's a lot of debate with sort of North America who talk about a thing called non-suicidal self-injury, is in actual fact that methods and motivations for individuals change. And it's an important signal of distress and crisis. It's a huge opportunity for intervention and support. And so I guess even if you took away the fact that it's one of the most important risk factors for suicide, the vast, so about half of people who take their own lives have got a history of self-harm. Sometimes that history might seem quite ambivalent. It could be quite risk-taking activity. It could be, swimming out or going surfing far enough, but not, might be behaviours where it doesn't look like there's an intent to die, but often there's a history of self-harm. But most people who self-harm will not go on to take their own lives, as Rory said. And that's an important distinction. So it's important in its own right. It's in the top 5 reasons for medical admissions. So if we think about all those pictures we see of ambulances queued outside A&E, self-harm has an important place in that sort of unscheduled, unplanned care. However, the vast majority of self-harm is a private, hidden behaviour. So most self-harm we do not see in services. So why do people self-harm? I put up some of the reasons from a PhD student's qualitative interviews with people. But this is a very well-designed survey, which means that you're talking to people in the community. It's not just people in contact with services. And what you see is about 3/4 of people self-harm. They talk about relieving unpleasant feelings, managing their anxiety and depression. About 1/3 do it in order to sort of draw attention. And the word attention can have negative connotations, but I guess what I would argue is it means people need attention. Or to change their situation. Now, if you look at this graph, the thing that is really interesting thinking about a future strategy is the difference in age. So in younger people, we're seeing them use self-harm to manage their feelings more than the older age groups. And if that way of managing their emotions continues into adulthood, then we're going to see a very different sort of impact on suicide and suicidal behaviours. Now, a few years ago, I remember getting contacted a lot by the press about, this is back in 2015, is self-harm increasing? It's increasing. We're seeing loads more numbers in hospital, loads more numbers of children admitted. And at the time, I would be going, well, it could be, that increase in admissions could be that we're getting better at managing self-harm, that we're getting better at the people who come into contact with services, we're actually doing something. But what these community surveys have shown us is there is an increase in self-harming behaviour in young people. And that increase is particularly in older adolescent girls who had the highest rates anyway. So that uncertainty I might have had what is it now, 8 years ago. I don't have that anymore. Self-harm rates are increasing. One of the projects that we did, so we do a lot of work, so some of my team is here, they're pivotal in delivering this work. We do a lot of work in routinely collected data in Wales, and we linked the education data set, so absences and exclusions in all the school children in Wales between 2012 and 2016 to their hospital and GP data. And what we found, I think actually for this one it was just their GP data, and that was 400,000 children. And what we wanted to see was in children who are persistently absent from school, so that's, for this it was any record after 10%, or excluded, and it could just be a day's exclusion, and we link them to their diagnoses. And what we found was that if you were absent from school, you were 3 times more likely, 3.5 times almost, to have self-harmed. And being from a more deprived area, being older, so, you know, the 15, 16-year-olds, because this was school-aged children, you were more likely to be absent and more likely to self-harm. And for exclusions, you know, in lots of the work I do, when we're talking about relationships, we're usually talking in the factor of 1 or 2 times bigger. For children who are excluded from school, and this could just be a day's exclusion, self-harm was almost 7 times more likely in those children, particularly if they were a boy, when they were older adolescents, and again, that thing, more deprived communities. So what does that tell us? This isn't about causation. You know, it's a bi-directional thing. You know, exclusions can lead to isolation and loneliness and shame. There are reasons why young people are excluded or absent from school. So I'm not talking about causation here, but I am talking about data that schools collect routinely that we could use, well, we and schools could use to highlight children in need of early intervention and support. Now, we're doing a lot of work in Wales on that, and Lynn has been pivotal in that, about the whole school approach, about integrating CAMS services, about well-being in schools. But having that data there, post-COVID, absentee levels have not returned to pre-COVID levels. Now, when you think about that on a population level, it's huge. You know, we're talking a few, I think it's still, now it's only a few decimal points, but percentage-wise, but the impacts are potentially huge and reflect underlying problems that we need to deal with. So another study we did, we linked primary care, emergency department, and hospital admissions data for children and young people up to the age of 24. So, you know, we know young people's brains are different. Their social circumstances, the rapidness of change, it is different. Their susceptibility to their peers. All they care about is their peers. You can see that on a brain scan. They're different. And that doesn't really settle down until they're about 24. And our services don't really reflect that. So what we found, we talk a lot about help seeking in men and boys. But one of the things we found here was that girls were much more likely to be admitted to hospital than boys. And the NICE guidance at the time said that if you presented to an emergency department under the age of 16, you should be admitted overnight. So at first I thought, okay, that's because girls are much more likely to self-poison and you need to monitor drugs. There'll be a medical reason for that. Didn't matter what the method used was. So what that hints to me is that, you know, we can put the onus on men and boys to help seek, but actually There's some reflection we need to do there about how we respond differently to males and females in distress. And that's something for us to think about that we can really do a lot about. Third study. I told you this was going to be hitting you with data. Our third study was based in the Suicide Information Database. And what we did was we took all the deaths by suicide since 2001 in Wales, and we linked them. And it's really important to remember, when I talk about this work, it's all numbers, it's all relationships, but actually when you're working with the data, it really speaks to you. It really is about people who are trying to seek help by contacting services. And what we found was that, so we had about 5,000 people in Wales over that study time period who had taken their own lives. And we matched them to people of the same age and sex. Consistently we found only, just over a quarter have been in contact with specialist mental health services. Most people are in contact with primary care. But a lot of people are in contact with primary care. So how do you identify who's at risk? Well, we found a few important things. A lot of those last contacts were for mental health problems, self-harm, and substance use. It's the same factors coming up again and again. But also what we found was there was an increasing trajectory in that year and even that week of contacts with services. So I think we cannot be over-reliant on that mantra that people aren't seeking help. They are seeking help. We need to make sure we give it to them. So thinking about the data in Wales, we have a rate in the latest ONS bulletin for 2021 of 12.7 per 100,000 people. That puts us sort of in the middle with England. Our levels for 2021 have reached pre-pandemic levels after that drop that we saw during COVID. The rates are slightly higher than in 2020, but not significantly so. One of the issues we have in Wales, we have about 350 deaths a year, and it means that when you're looking at the data, it's what we call very volatile. The numbers, they're vitally important for us to do something about, but in statistical terms, they're small. So when you start boiling down to local authority data, you really need to be looking at 3 to 5 year rates. And that's really important to think about. One of the issues that came up in that ONS bulletin is about the delays in registration. So that's the delays in coroner's inquest to being able to register the death as suicide. Now, some of that was the disruption of COVID, but we've always had higher delays than England. And now they're huge. They're much bigger. And the reason that's important is because those delays are happening for bereaved families. They're not receiving the coroner's inquest. They're having that delay while they're waiting for this thing to happen. And so I think that's an important thing that we need to do something about. So I'm going to show England and Wales for this because of the numbers involved. So the male rates for all age groups are higher in 2021 than 2020, except in over 75s. And the highest rates, and this has been long-standing, I guess when I first worked in suicide prevention, it was slightly younger men, but it's middle-aged men. The highest rates are in middle-aged men. That's why we focus on them. We've talked about inequalities. Suicide is much commoner in particularly men from more deprived communities. They're much more likely to take their own lives. And when we think about some of the risk factors, like alcohol use, The thing is, there are all sorts of cliches out there about alcohol use being much higher in poorer communities. Sometimes it is and sometimes it isn't, because they also don't have as much money. But, and it's called the alcohol paradox, lots of these factors impact deprived communities in a more harmful way than in those with many more resources and assets to manage them. So it's really important, and I guess the paper on the side was led by a public health registrar and shows that an admission for an alcohol-related event increased your risk of suicide. So we need to get better at clinicians outside mental health services being enabled to ask those questions of people about their mental health and suicidal thoughts. Suicide and occupation. Okay, I know. We were running 10 minutes over. I'm going to whiz now. Highest risk, construction workers and care workers. That's Wales and English data. So when we are thinking about the potential coming recession, financial adversity, we can target the professions that we know are at higher risk. Females, middle-aged females have the highest rates, however, and younger females have the lowest rates. But what we see is, compared to 2015, there's a statistically significant increase in the suicide rates for younger females. So that's really important. And I guess what I would say is the reason we focus on all three ends, the middle, highest rates, middle-aged men, 3 times as likely as women. Young people, the rates are low for suicide, but they're increasing over the last decade. That's why it's important. And then there's another increase in older people. Think about bereavement, loss of identity, lots of reasons there. Suicide is the leading cause of death in children and young people. Ros leads on the Child Death Review. I've worked with her twice over the last decade to review all the deaths in children in Wales and identify themes. It's very in keeping with other work. Looked after children who self-harm, mental health issues. The other things that really struck me, bullying, sexual assault. You know, we need to be supporting young people who experience sexual assault, even if those things aren't going to lead to conviction. That's one of the issues we had. Not living with their parents. The number of young people but over 16 sofa surfing across houses. So I'm going to run very quickly through the recession. You see increases and decreases. So we saw decreases during World War I. Social cohesion, honeymoon period, maybe that's some of what we saw during COVID. I also think that increase we're seeing in male suicide compared to 2020 and 2021 shows you that reduction during COVID was very much driven by male suicide and delays in registrations. There's strong and consistent evidence of the link between unemployment, debt, financial adversity, and increases in mental illness and suicidal behaviours and suicidal thoughts. I'll whip through it. We could all do this. You know, the reasons that happen: shame, relationship breakdown, challenging coping behaviours and thoughts and mental health problems. Back to that ONS data, we saw an increase in suicides, about 1,000 excess deaths following the 2008 recession. There are lots of studies that show you get increased rates of self-harm in the areas where there are increased rates of unemployment. And people attribute that to work, financial and housing problems. You see the same thing in mental health inpatients. We're seeing this across the board, men more than women. If you talk to people who've made suicide attempts during that time, during the last recession, They talk about not being able to get help for their employment and financial adversity issues. We can do something about that in our services where they are seeking help, which we've just talked about. This graph, led by Marcos Pozo-Banas, who's here, shows you that red line is the drop in contacts compared to 2016 to 2019 for self-harm. Now, the importance of that is none of those people got psychosocial assessments, those people who didn't contact services, because they were protecting the NHS, they were scared about infection. But if you look in the lower graph, that's deprivation. The purple line shows you the drop in contacts from our more deprived communities was bigger. So the impacts may be disproportionate. And that fits in with everything we saw post-COVID. So can we make a difference? So sometimes you feel a bit helpless about deprivation and poverty and economic adversity. Actually, we can. There are really good studies that show that active labour market policies, rather than austerity, make a huge difference and actually save money with minimal spend. Active labour market programmes, classroom job training, subsidised private sector placements. We could think about focusing on those high-risk groups. People in hospitality, construction workers, young people. People are experiencing financial adversity because, even government's experiencing challenges. So, we might have to be targeted in our approaches about income protection. Huge increases in relation to suicidal behaviours and debt. We can give people debt advice. We need to make sure that people on the front line across services, citizens' advice bureaus, healthcare work, can give advice to national and local services that can give advice. So I know Welsh Government is acting on that. And we need to make sure people in services understand the importance of that, and the near real-time monitoring will enable us to keep an eye on what these trends are and be much more responsive, but also get help to people bereaved through suicide in a much more timely way. So I'm going to, 3 slides. Not all recessions will be the same. The last recession, the focus was very much on men, but we've had COVID, and there were groups that were disproportionately infected. Young people, ethnic minorities, people from deprived communities, and people with a previous history of mental and physical illness. Every study I was in, it was the same groups. So we don't know if the impact this time is going to be the same. We're terrible at having good ethnicity data, not just in Wales, across the whole country. It's poorly recorded. It's important in this field that we have it. And part of the reason for that is we know that people from ethnic minorities experience much more coercive pathways in mental health and suicidal behaviours. There's much more contact with the criminal justice system. People from Black or ethnic minority backgrounds are much less likely to receive a psychiatric assessment when they present to an emergency department. These are all things we need to address. That all said, all the issues with the data, the surprise to all of us when this came out, and a few of us worked with the ONS on this piece of work, was it was people from mixed ethnic minority backgrounds that had some of the highest rates. This is an ever-growing demographic in our population. And it fits in with some of the things that Rory was talking about. You wonder, is it about belonging? So we really need to keep an eye on this group. I won't cover that because I've basically said all of that. And then just to say the other thing, those things that make it really important to have a suicide prevention strategy is the impact of reporting on clusters and behaviours, on people identifying with both celebrities and people in their close vicinity. And there's lots, so we do that work in the National Advisory Group, but I also work with Samaritans nationally on a number of soap storylines to make sure that those are reported responsibly. And then I guess the whole online thing, I have 3 things to say and then I'm done. 1, there are harms, there are also potential benefits. It's not a dichotomy. Okay, those harms and benefits vary between people, but also vary for the same person over time. You know, those conversations, looking at those images, they really change. But also, people get support. People talk about their recoveries. Talking about recovery can help others. Whatever, it's not going away. So we need to think about teaching young people behaviours, digital citizenship online. How can we expect them to be like that when you see the behaviour of adults? You know, so there's modelling. Everyone wants more agency over what they see. So one of the big things we've been pushing for with the online harm bill is if you look for self-harm, then like your For You page on Insta and things will push content towards you. If you can make an algorithm do that, you can make an algorithm that doesn't do that. People want more agency to control their feeds. And we also, in services, need to be asking people. You know, there's lots of evidence out there that people are using the online environment to look up information, to understand how they feel. And we need to be asking them about their online activity. So I don't know how much. That's the strategy from WHO, covering all the things we have in our current strategy. So I don't know how much I've run over, but I'm sorry, Claire. Well, I didn't start it.